Welcome, I'm Deborah, and I have been exploring the topic of whether virtual reality can treat social anxiety using the principles of classical conditioning. Today, I'll discuss a paper on this topic, Kapman et al. 2016, titled Exposure to Virtual Social Interactions in the Treatment of Social Anxiety Disorder, a randomized controlled trial. Now, before we jump into the article, I want to explain some of the concepts and terminology. So first of all, social anxiety disorder, or SAD. So it simply means a heightened fear or anxiety of being judged in a social situation. In Australia, according to research done in 2013 by Yassin, anxiety disorders are the most common of all mental disorders. Kapman noted that the most common treatment for SAD is cognitive behavior therapy, or CBT, where the unhelpful behavior is unlearnt, and a common component of CBT is exposure therapy. Virtual reality exposure therapy, and I'll just refer to that as virtual reality, is where the client is asked to face the fear or anxiety using that technology. So think the Matrix. Interestingly, the principles of exposure therapy were developed by Joseph Wolfe in 1958, and he called it counter-conditioning, unlearning the association, as it was counter to classical conditioning. So now that we have that context, let's have a look at the rationale of the research paper. So the authors acknowledged that the virtual reality had positive results in treating specific phobias and cited past results from over 10 studies. But, and this is why this research paper was deemed important, the authors noted gaps, some unanswered questions. So could virtual reality be used to treat generalized SAD? Could virtual reality be a standalone intervention without cognitive elements, without cognitive behavior elements? Could virtual reality be effective with diverse virtual reality scenarios and longer dialogues? The authors noted that virtual reality exposure therapy as an intervention had not been quantified in that way, and that's what they set out to prove. So the aims of the study, as you can see on the PowerPoint screen, it's a more concise statement of the key elements of the rationale. So the participants had to have a diagnosis for generalized SAD, the cognitive elements were removed, and there was a wider range of exposure scenarios. The hypotheses that were participants relative to the control group would report fewer social anxiety symptoms and perform better on a behavioral assessment task at post-assessment and a 3-month follow-up. This was operationalized by the primary measures, so there were 5 social anxiety scales and a secondary measure, which was a behavioral task. So how did this come together? So you can see that the recruitment of participants started with 194, and after screening and pre-assessment, it ended with 60 participants who were randomly assigned to the 3 groups. The criteria was the SAD diagnosis, the median age was 36.9, age range 18 to 65, and 63.3% were women. The research design, it was a group comparison and randomized controlled trial. So there were 5 primary scales and a secondary behavioral task to evaluate anxiety levels over time, so from pre-assessment to post-assessment, within group and between groups. So it was predicted that over time, the anxiety levels would decrease. The research method, the design of the exposure treatment, was based on the protocols from Scholing and Immelkamp 1993 and Hoffman and Otto 2008, and was the exposure only. Both groups had 10 90-minute sessions, and the actual exposure component took up 6 sessions, 2 30-minute blocks, from the 3rd to the 8th session. There was no homework. The virtual reality sessions took place in the laboratory in the University of Amsterdam, and the exposure sessions took place around the uni. So here are the findings in Table 2. So there's a lot of detail, so let me see if I can simplify this a little bit for you. The results covered 9 measures overall for the pre-assessment, post-assessment, and 3-month follow-up across all 3 groups of participants. The results revealed that the participants in the virtual reality and the exposure groups improved from pre to post-assessment compared to the wait list on social anxiety symptoms, speech duration, perceived stress, and avoidant personality disorder-related beliefs. So in a nutshell, the findings supported the beliefs. When looking at the method and the design, some of the weaknesses that may have impacted the results. First, there were some limits to the virtual reality scenarios that the participants could engage in, and there was some commentary that the facial expressions on the virtual humans were a little stilted, so that may have reduced the effectiveness. The participants in the exposure group had the opportunity to practice, so the social situations were not identical, and that may have improved the results for that group. For both groups, there was no homework and there was no cognitive elements. Now, the homework is practice outside of the sessions, and this potentially affected both groups, and it was noted that if both of those elements were included, it would have benefited both groups. Some of the strengths that I noted, and in my opinion, the research design was robust and the methodology was sound. The internal consistency measures or correlations were sound, and the two treatment groups did not significantly differ, increasing the reliability. It was noted, and so as the article as a whole, there was a couple of observations that I had. So it was noted the virtual reality group was less effective than the exposure group in some domains, and the results were less conclusive to other studies, Anderson et al. 2015. Now, this was justified by the authors as it was the first attempt to apply diverse scenarios to diverse social fears. Some of the strengths of the studies included that virtual reality was effective without the addition of cognitive elements, that it was effective for participants with generalized social anxiety, and that it could function as a standalone intervention. And this, as you may recall, were the aims of the study. So the findings suggested that virtual reality exposure therapy was potentially effective in reducing generalized SAD. And it correlated with similar randomized controlled trials. So what does this mean, and what are the implications looking forward? The ones noted in the study relate to how virtual reality exposure therapy could be used in a clinical setting, and that it may be used as an assessment tool and as a first step. It was noted that virtual reality could provide therapists with a flexible and easy-to-use tool in sessions. It was also suggested that in the future, the possibility of automated treatments might be an option, and it was noted that as the world of technology advances, so too would virtual reality. Thank you.